we'll start our course, which is essentially on basics of squint amblyopia. And the aim of this is to acquaint us and manage patients which we see on a daily routine basis. So this will be, I'll be starting on refraction and prescription of glasses, and subsequently we'll go on to the next set of topics. I'll request Professor Pradeep Sharma to please come on the dais. Okay, Dr. Ankur, Dr. Digvijay, if you could please come on the dais. So I'll be talking on refraction and prescription of glasses. So the first question that we need to understand is, why do we need to know? It's important because it's essential that we understand what is the appropriate vision at any particular age. When does the child reach adult levels, so that we are able to understand whether the child's vision is subnormal or not, and if it is so, how do we investigate and manage it? So the process of emetropization, the infant's eye moves through a wide range of refractive errors. So actually at start in infancy, although a majority of the children are hyperopic with a mean of about 3 to 4 diopters, they can even be myopic in the early infancy. So there is a wide range of refractive errors a child may have in infancy, and during the first 3 years of life, there is a significant movement which may initially increase the hyperopia and then progressively move towards emetropization. So initially there is an increase in the axial length, and the cornea and lens lose their power by flattening, and by 3 to 6 years, although there is not so significant change in the axial length, but dioptric power of the lens decreases and not so many changes in the cornea. So actually it's the changes in the lens in the 3 to 6 years that start change the power of the eye and move towards emetropization. The development of vision is also not complete at birth. So rods and cones mature by 4 months after birth, and visual myelination is continuing till 1 month after birth. And complete maturation of the pathway with complete myelination takes up to 2 years. So it's not that child is born with complete 6/6 vision. It may take up to 2 years, depending upon the way we are measuring visual acuity, that we would get visual acuity results. The important milestones, therefore, that we should be acquainted with is that at birth, the child is having intermittently visual fixation. So the child will fix at a nearby target, often particularly a mother's face. So high contrast objects are the ones which a child can fixate on. Following, and subsequently they will be following, so they will have some movements for following anything, including an optokinetic nystagmus and any object, bright object, which the child can fixate on. By 2 to 3 months, he is fixating well on near objects, and the follow movements are smoother. By 6 months, the distance objects, the child is able to fix on distance objects. The child is sitting now, often without support, and he's able to look at parents, objects which are fairly far away. By 18 to 24 months, the visual acuity reaches adult levels, particularly on most visual system measurings that we can do. And by 5 years, adult stereopsis levels are absolutely achieved. You can have different methods of measuring visual acuity. You have distant detection acuity test, where they're just being able to detect any object like candy beads or graded balls. The other method is to see for resolution acuity, so whether they are able to resolve various objects into their particular into its components, like using an OKN drum, using preferential looking tests I'll be showing you, and pattern VEP. And subsequently, the best method, which is also most helpful for testing for amblyopia, are recognition acuity test, where a child is actually recognizing an object, like Cardiff acuity, where there is an object which a child recognizes, Allen cards, toys, Land.C, E, and finally, of course, ETDRS or Snellens. The change of visual acuity happens as they go. Again, like I said, it depends upon the method used. You can use OKN, preferential looking, or VEP, and this is the time by which they achieve 6/6 vision or adult visual acuity, depending. Again, the fastest achieved with VEPs, because there are no responses required. You're actually testing the anatomical pathway. They see the pattern, and you are getting the results. So the earliest achievement of visual acuity is on the VEP. The other methods to look is the Bruckner's reflex, where you can identify any abnormality, either amblyopia or strabismus, and you look at the reflex and compare it between the two eyes. It's also in children easy to pick up whether they have amblyopia by doing the preferential, by fixation preferences. Sometimes it's not easy to pick the visual acuity, but just by observing their behavior on covering of the either eye, you can see the left eye, there's hardly any resistance. So the right eye is the fixing eye, but the moment you cover the right eye, the child is extremely unhappy. So these are ways of indirectly being able to understand the presence of amblyopia. The teller acuity cards, now of course the teller cards are available without the sheet around it, and it's graded patterns are there of different sizes and distance, and they are able to, you're able to compare that with the adult comparative visual acuity, and it gives you in cycles per degree. So that's cycles per centimeter. So that's how you are comparing visual acuity in children. It's based on the preferential looking. So the child will look towards the pattern if you can see it. However, if the child is not being able to see the pattern, it resolves, it merges with the gray background. That's why the gray color of the cards. Similarly, the Cardiffs, they are called vanishing optotypes, because if you are not able to see these objects, they vanish into the background. So it becomes an absolute gray, and there is no place for the child to fixate. So that's why the preferential looking. So the child looks preferentially to any object. And also that is why there is a limit to which these cards are successful. They are useful for smaller children up to 2.5 to 3 years, teller for more younger children from 6 months to 1.5 years, and the Cardiff for a little older children. They bank upon the preferential looking behavior of the child. So they are behavior based, and therefore in older children where we are not expecting this behavior to be a standard, they are not very useful. Others, of course, become the OK and drum. Again, various charts of forms, and again, Snellen's modifications of objects which can help to identify the visual acuity. For refraction, particularly in the presence of esotropia, we prefer atropine ointment, particularly 3 times a day for 3 days. The preferred over drops, because they less chances of the drug running down the nasolacrimal duct and getting absorbed systemically. It causes blurred vision for a period, and therefore it is important to inform the parents about this. Extremely important that most of what we call as side effects are essentially drug dependent toxicity, and overdose is something you have to be very careful about. Drowsiness, flushing, sometimes even seizures, and fever is also something that is not uncommon. Homatropine and cyclopentylate are alternatives. Cyclopentylate is particularly being used in the West as a replacement to atropine for refraction. However, we do find significant CNS related toxicity with cyclopentylate, and therefore we still prefer atropine or the alternative of homatropine. Retinoscopy is extremely important. The child should be comfortable in the parent's lap. You should be bang straight ahead so that you avoid off-axis errors, and should have preferably a fixation target in the distance. It's important to have the child comfortable and not scared or daunted. Prescribing for myopia, mild moderate myopia is a low risk for amblyopia, as near vision is not affected, and therefore we generally prescribe for higher myopes. I'll be showing you the table that we use. Again, for astigmatism, powers above 1.5 to 2 diopters can be amblyopiagenic, and therefore it is important to prescribe them. Oblique astigmatism, even more than 0.5, 0.75 diopters are important, and therefore need to be prescribed. Early school years, even 1 diopter of astigmatism is relevant, and therefore it is essential that we identify astigmatism on our retinoscopy and correct for it. Anisometropia, hyperopic anisometropia is more amblyopagenic than myopic, and therefore again that becomes important to early identify and treat. Myopia more than 3 diopters is really amblyopagenic, because till that time the child is able to use 1 eye for near. However, of course, if you identify, you need to treat, because binocularity is essential. Bifocal glasses, normally this is what we give for adults, but for children, especially when we're looking for a convergence excess pattern, +4 ads or +3 ad is given, which can be gradually tapered. They are large executive type with line bisecting the pupil, so that the moment the child's visual axis falls below the primary, he started looking for, it's expected that he's looking for near objects. And then you follow up for accommodative esotropias, for amblyopia, for refraction, for residual deviations, and remeasure at distance and near. And it's important to gradually taper this hyperopia as the child grows and the requirement decreases. Intermittent divergent squints, it's very important to remember that intermittent divergent squints require refraction, particularly if the vision is less than 6/6. A good high quality image is the most important stimulus to provide for control. Therefore, if you have a patient with myopia or high hyperopia even, it is an essential that you treat. For hyperopes, you may slightly undercorrect. However, myopes require optical correction for the best visual acuity. This is a modification of the AO guidelines, which are in red, and we recently had this discussion where we established guidelines, which is a suggested guidelines for Indian persons, Indian patients and children, some of which I have actually highlighted. This was released yesterday in the inauguration, and I'm sure all of you would be getting it. But essentially, as I discussed, these are important guidelines which tell us what is the cutoff when we should start giving glasses. And when to refract, it's very important the moment there is any misalignment, if there is any difference in the Bruckner's reflex, a refraction and prescription should be given. But it's again important that at every age there should be an identification, particularly by 3 years, a comprehensive eye exam by an ophthalmologist at least once becomes essential. Again, like I said, atropines are preferred for young children and for those with esotropia. And cyclopentolate can be an alternative, and if there is no strabismus, you can use any of the drugs. It's important to prescribe, as we have discussed, these are the important conditions, but it's very important if children with developmental disorders or delayed milestones, it's very important to prescribe as per retinoscopy, because you are unable to often be able to do a PMT. So to conclude, pediatric prescription is not the same as that in adults. Important factors to consider are accommodation, visual needs, emetropization, the age, the amblyopic age up to 6 to 7 years, and ocular alignment, and a cycloplegic retinoscopy is a must. Thank you.
Thank you, Dr. Rohit. Now I would invite Dr. Digvijay Singh for his talk on challenges in a pediatric eye exam. Okay. So I think Dr. Swati will present first. Recent advances in the management of amblyopia.
Good afternoon, all. I'm here to talk about management of amblyopia. It's not moving. It's not moving. So amblyopia by definition is unilateral or bilateral decrease of visual acuity because of either pattern visual deprivation or abnormal binocular interaction, where no cause, organic cause, can be detected by the examination of the eye. And if it's treated early, it is reversible also. The pathophysiology of amblyopia lies in visual cortex, where the Hubel and Wiesel theory, with their experiment, they have found that that in 4C layer of visual cortex, the ocular dominance columns are present. So the efferents from the eye, which is suppressed, the ocular dominance column of that eye gradually decrease in size, leading to the cortical suppression. So that is the basic pathophysiology of amblyopia, and therefore the age of plasticity is very important, that we treat this condition during that period, so that this cortical dominant column can again regrow. So amblyopia can be classified as strabismic amblyopia, ametropic amblyopia, anisometropic amblyopia, and visual deprivation amblyopia. We all are aware of the causes for the same. As Dr. Rohit in detail discussed the ways of measuring visual acuity in children, there are various ways. You can directly measure visual acuity, or you can look at the fixation pattern. You can also look at the presence of squint, which gives you an indirect idea of poor vision. There are other clinical features in amblyopia, such as crowding phenomena, where you find that the linear visual acuity is worse than the single letter visual acuity. So this is a crowding phenomena. Neutral density filter, if given in the better eye, the amblyopic eye functions better in mesopic conditions as compared to photopic conditions. Then the amblyopic eye also shows abnormal or decreased contrast sensitivity. There is decreased stereoacuity, and often the near vision is better than the distance vision. The speed of reading is also affected in such cases, and color vision can be defective depending on the grade of amblyopia. Management of amblyopia, the key lies in early identification of the cause, the evaluation of the cause, and the intervention according to the cause of the amblyopia, especially at the critical age group, which may ensure the complete or near complete visual recovery. There are various factors that affect the management of amblyopia, just like age of patient, refractive error, type of amblyopia, and compliance from the patient's side. So as I said, the main goal is to achieve equal vision in both the eyes by identifying the cause of visual loss, by correcting the refractive errors adequately, and by stimulating the amblyopic eye preferentially over the dominant eye. How do we do that? There are various treatment options: optical correction, occlusion therapy, penalization, active vision therapy, and pharmacotherapy have been well documented. So proper refractive correction is the single most powerful intervention in the management of amblyopia. Even the Pediatric study has shown that if you give a proper refractive correction, be it any age, particularly during the age of 3 to 7 years, 70% of patients will show improvement of vision. So it's a single most powerful tool to correct the amblyopia. Even before you go for occlusion, one has to give a proper refraction that will work in cases of moderate amblyopia, not just isometropic but strabismus as well. So these are the guidelines for prescription of glasses, and Dr. Rohit has already discussed about it. Now there are engine consensus for the same that have been released yesterday. So those will be available soon with us. Occlusion therapy is still the gold standard for the treatment of amblyopia, but the success rate depends on various factors. There is quite a debate about total versus partial part-time occlusion, but now the Pediatric study has substantially established this fact that the part-time occlusion is as good as full-time occlusion, especially in mild to moderate amblyopia. So you have to keep that in mind, that it is good for mild to moderate amblyopia, not for severe amblyopia. So this is a table where various patching regimens were compared by Pediatric studies, and they have found that the 6 hours daily occlusion is as good as full-time occlusion in a case of severe amblyopia, and in case of moderate amblyopia, the 2 hours occlusion is as good as 6 hours occlusion. So they showed that the number of lines of improvement was same in both the groups. So generally now we have shifted to part-time occlusion, where we prescribe around 6 hours occlusion per day. There is a need of occlusion therapy which should be done before the surgical correction of the squint, because it's easy to identify the squinting eye and then you know which eye is dominant over the other. It also gives time for the improvement in amblyopic eye, and also ensures compliance, because once the squint is corrected, the motivation to do occlusion is decreased. Then not at all times that occlusion therapy can be successful. There is occlusion failure, which is defined as no improvement in visual acuity in the amblyopic eye for 3 bimonthly consecutive follow-ups. Usually in a normal case, the improvement is seen at around 3 to 4 months, but if it's not occurring on consecutive follow-up, then one may have to consider it as an occlusion failure. The most common factor is the poor compliance, more than anything else. Maintenance of occlusion therapy, the Pediatric study have shown that rather than abruptly stopping the occlusion, we should actually slowly and gradually taper it in terms of duration. So from 6 hours, you make it 4 hours, then you make it 2 hours, depending on the response of the patient. And you have to continue occlusion till the age of plasticity is over. In spite of all the best efforts, it has been seen that the recurrence of amblyopia can be there in around 6 to 67% of cases that has been reported in literature. In a study done from our center, it was seen that around 12 to 13% of cases do have a recurrence even after the successful treatment. There are various factors which are responsible for the treatment, for the recurrence of amblyopia, like older age of onset of treatment. If the degree of visual recovery is large, then you will understand that the loss of visual that the visual loss will be equally, the recurrence will be equally more. So a better visual acuity achievement after the cessation of therapy. Younger the age, so if you stop occlusion at the early age and abruptly, there are higher chances of recurrence. The strabismic and mixed amblyopia have a poor prognosis as compared to an isometropic amblyopia. Other than occlusion, we have penalization, which can be done optically as well as pharmacologically. This has also been studied by Pediatric group, and they have found that the atropine is equally effective as a part-time occlusion in cases of moderate degree of amblyopia. The major advantage of pharmacological penalization is that it allows binocular interaction, which is not there in occlusion. Drugs like levodopa, citicoline have been tried, but their effect is very temporary, and long-term results are not very good. Now, nowadays we are talking about active vision therapy, where we use video games, where the patient is asked to use video games along with the occlusion. So the dominant eye is still occluded and the patient is playing video game with the suppressed eye. So that gives a motive to the child to use occlusion, as well as also provide some active vision therapy to the child. So a study was done at our center where the monocular video games were given, and we found that these video games do act as an adjuvant therapy to the occlusion in improving the visual acuity. Nowadays, the recent advancement in management of amblyopia, there is a role of dichoptic. Dichoptic stimulation is basically the ability to present different images to each eye, so that both eyes are used simultaneously and independent of each other. So the approach is by providing viewing condition that the two eyes that allow the two eyes to work together, and that is because of the gradual alteration of intraocular contrast, because the suppressed eye or the amblyopic eye usually have poor contrast level. So the difference between the two eyes, the difference of contrast between the two eyes is used as a tool to provide stimulus for this kind of therapy. So the study is still underway under the guidance of Dr. Rohit and our center, and results would be out soon. But the literature has shown that this dichoptic stimulation has helped not only in children but in adults also for the improvement of amblyopia. This is factors which can predict the recurrence of amblyopia. I think I've already spoken about it. So the management of amblyopia is basically to rule out all the causes that can cause amblyopia, to do a proper cycloplegic refraction, and it can never be, the role of refraction can never be overemphasized, to find out what is the type of amblyopia, to give occlusion therapy, and to ensure compliance, to do regular follow-ups, and then gradually taper the therapy, and also give maintenance therapy when required. Thank you.
Thank you, Dr. Swati. We'll go on to challenges in the pediatric eye exam. We may then take one or two questions before we go on to the types of strabismus and other detailed management. So just hold on to the questions. We'll have challenges in a pediatric eye exam. Dr. Digvijay Singh.
Good afternoon, everybody, and I thank Dr. Rohit to have me a part of this course. So we'll discuss something that we do frequently face, and as pediatric ophthalmologists, the pediatric eye exam, we're it's the commonest thing that we'll probably do, and I'll come quickly to some of the challenges, and there are some solutions that I've thought of. There are a lot of other solutions that are there, so we can always discuss them, and we're really happy to know everybody's point of view, and if you guys are doing things differently, I'm sure that we'll be happy to if you can share that with us. So I think the first thing in the pediatric eye exam is the history. And the challenge actually starts right away, because here the informant is important. And very often in our country, the informant may actually be somebody different compared to who is actually staying with the child. So it's very important to try and get information from the person who's taking care of the child. It could be the grandmother, the mother. So that's very, very important. The other is the complaints. So a child can't usually tell the complaints. So the parents will tell the complaints, or the informant will tell the complaints, and they're often incomplete. So it's important that you do some direct questioning. So that's very important. Does the child rub the eyes? Do the eyes get red? Does the child tend to rub one eye more than the other? So some direct questions are very important when you come down to this. And always, you can always ask the child in a local, friendly manner. And a lot of children, even young ones, will be able to give you some idea that they're feeling some pain, some itchiness or the other. So that's a very important thing that you need to look at. Then the duration. So for duration, again, there is often a confusion, and many times they'll not talk about it from birth. They'll say it was noticed later on, things like Duane's retraction syndrome. Parents say, no, it started only at 3 years of age. They probably didn't notice it earlier. So old photographs, go a long way on looking for that. For family history as well, this sibling or who's come in maybe, having a very sort of prominent squint, but the other sibling could not. But, you need to examine, because you'll actually realize that it's probably there. Or likewise for refractive errors as well. So that's important. And treatment history, again, the parents or the informants themselves are the treating people. So one, that they may not be sure on how they're treating, or even if they are, they'll often misreport it. So they'll say, yes, he patches the eye every day, because otherwise they're the ones at fault. And so it's always important to kind of reconfirm that with them. And for treatment history, again, direct questions work well. And always ask, 2 separate informants. That's what I always do when I need to make sure on compliance issues. So remember, history goes a long way for the pediatric eye exam. So in examination, some of these points have already been covered. So in vision, children are not very cooperative. They may be pre-verbal. They cannot read the charts. Even if they can read the charts, their attention span is small. So there are a lot of indirect ways of checking the vision. But most important, one has to be patient. So you have to have patience. In a pediatric eye examination, that's probably one of the most important things. But yes, we've gone through some of these using special charts and sweets. So treats work very well. So reward them if they're telling you, and then this will go a long way actually in the child cooperating with you. Assessment of vision I won't go much into. For refraction, likewise, it's a challenge in children because they'll often not be cooperative for the autorefractors. That's number one. There'll be a lot of variability in the refraction. You have to do a cycloplegic refraction. They hate cycloplegic refraction, so they don't want to get eye drops put. That in itself is a problem, and you have to make sure that the child actually has had proper cycloplegia before you go ahead and perform the refraction. So these are all aspects, challenges that come around in the form of refraction. And the solutions, of course, lie in the form of, so retinoscopy is a very, very important thing. Of course, the treat always works, so that sweet box should always be with you. You have portable autorefractors. It's not something that we routinely advise or ask you to do. If you do a good retinoscopy, that itself goes a long way. And you must use cycloplegia, and as has already been discussed. For the head posture and external adnexa, again, cooperation is sometimes an issue. You aren't sure if the child is actually being able to hold the neck as well properly, or if that's for a very young child. But older children, they'll often get conscious. So you must look at them when they're not, when they're not conscious of the fact, or when they're walking into your room, or if you're talking to the parents. From the corner of your eye, have a look at what posture the child is keeping, and that's very, very important. Likewise, for external examinations, you often have to do a distant examination and use indirect clues. If you can't sometimes evert the eyelids to look for papillae, but the condition of the conjunctiva and the cornea can give you a hint that he's having a severe VKC. Ocular alignment and movements, again, some of this has already been discussed by Professor Rohit earlier. Again, children are uncooperative, and you'll often have variability in findings here, particularly when you're looking at ocular movements. Again, you can use Bruckner's reflex, you can use corneal reflection tests. And for ocular movements, you can use toys in very younger children, and you can patch one of the eyes, if the child doesn't allow you to cover the eye physically. So you can patch one of the eyes and then check them individually, alternately. So that's important. For cataract examination, or essentially the lens examination, the challenge again is that they're quite uncooperative. They'll not sit on the slit lamp, the younger ones particularly. So here the distant direct ophthalmoscopy works very well. You have portable slit lamps. I've used a few, sometimes cumbersome, but yes, they can be if you want to define the type of cataract that's there. But more, sometimes you have to do an examination under anesthesia in order to be able to pick up what's there. Fundus evaluation, somewhat easier, but still children are uncooperative. They'll again require dilation, and sometimes they're too young for the regular eye drops, so you have to dilute the eye drops. So that's important. You have to be able to do a good indirect ophthalmoscopy, and that's very important as well. So small children like ROP, you can double dilute the eye drops, and sometimes you need to make the child comfortable and use different devices. So here I'm using a portable fundus camera in a child who's having a lot of nystagmus, so one click and I'm able to catch it. But again, an indirect would have done exactly the same job for me. Intraocular pressure, again, a difficult thing to do in young children. The question we do need to ask ourselves, is IOP really necessary? So in a lot of the times in the very young children, you can actually get to know if there's glaucoma or the IOP is high by looking at the cornea, the condition of the limbus, and other things. So, you may not actually require the absolute value, but If you do, then there are alternative you can do a non-contact tonometry in some children who can sit down and cooperate. At least one eye you can get it before they realize, or use a a Parakin local anesthesia topical eye drops. You can do it with a Perkins, with a tonopen or an eye care. But sometimes you have to do an examination under anesthesia, particularly when you're taking therapeutic decisions. And IOP becomes important if the child is being treated with steroids for something else, like a nephrotic syndrome. You do want to make sure that there is no steroid response. Stereoacuity, again, a little bit of a niche thing here, but children are uncooperative, so you can either use this. I've seen the Frisbee-Davis distance. Even very young children, they understand and they're fairly okay to cooperate as long as you make sure they hold their head straight. And you can use some tests like this Lange test here. The 2-pencil test works very well for a gross stereopsis. Again, you don't necessarily require this in all patients. There are a lot of other challenges which continue to remain, like the gonioscopy, again, would not be possible very easily. Color vision, children will not cooperate. You're not sure if they're actually having color blindness, or they're not cooperative with you. Similarly, for other investigations like perimetry and all, so that's another thing. Confrontation perimetry works well. Otherwise, Goldman applanation tonometry is difficult to do. So, some of these things are there, and of course, I'm sure we'd like to know from the dais as well what their thoughts are. Thank you.
Thank you, Dr. Digvijay. Any questions, couple we can take maybe before we go on to the squint disorders, esotropia, exotropia, and the decision-making on management. So we've covered basically on examination techniques, on how we can manage and treat amblyopia. A lot of changes are now appearing for management of amblyopia, has been discussed, like dichoptics, and we hope that with time management of amblyopia can be a more pleasant and a happy time for children as compared to the patching that we are currently forcing them to. We'll go on to the next. Dr. Suma is unfortunately not able to come, so I'll be talking about tackling esotropias.
So esotropia is one of the common problems we have. I mean, most of the prominent squints we have is ESO and the exo. So we'll be first discussing about esotropia. How do we diagnose and manage the esotropic patients?
Dr. Suma was unfortunately taken ill at the last moment, and therefore I've just replaced the topic so that we can cover it. So I'll be talking about childhood esotropias. And the most important thing I would want to start with is that any time you're reading, discussing, thinking about strabismus, keep your mind open, and this is the kind of flowchart that we're looking at. So you could have squints which could be apparent or pseudo squints. There could be latent squints, essentially that are presenting at some time, and sometime they are aligned. So like intermittent divergent squints, they could actually be manifest, which the squint presents all the time, and it's easy to pick up. The manifest squints can be comitant and incomitant. The incomitant will be presented in the keynote lecture at the end of this, near the end of the session, but they are essentially paralytic, restrictive, and spastic. And the comitant squints can be esotropias, exotropias. You could have the comitant squints, particularly esotropias, divided into the accommodative and the non-accommodative part, which I would actually be discussing. So any kind of squint is actually going to be placed somewhere here on this table. Comitant esotropias would be accommodative esotropias and non-accommodative esotropias. So accommodation is a factor that is significantly changing the amount of esotropia or the presence or absence of one. And the most common non-accommodative esotropias that we come across are infantile esotropias. The others are of course present, including cyclical, acute onset or late onset, and acquired basic. But the accommodative are the ones where you can see a variability, a change that can happen just by providing refractive correction, which is important to pick up, so because you do not want to operate on an accommodative esotropia. So first, of course, pseudo-esotropias, parents come bringing small children that my child is squint. Particularly mothers will say that my mother-in-law is particularly worried that my child is squint, and you just need to see the corneal reflexes, and you realize that although from far it looks as if there is an esotropia because of the epicanthal folds or a flatter nasal bridge, but the moment you shine the light, you're able to see a well-centered corneal reflex. You can confirm that by covering either eye, there is no movement in the eye, so it is a pseudo-esotropia. If the parent still insists that the mother-in-law is not satisfied, you'll require to treat the mother-in-law and not the child. So that's the important thing, to identify, diagnose, and reassure on pseudo-esotropias. Again, it's important to remember many of these children may later on develop esotropia. So it's not just see once and send. They may be currently in the intermittent esotropia phase, and the parents and the mother-in-law may actually be right. So not all mother-in-laws are monsters. So maybe she's picking up, she is the one who's looking after the child, and she sees the child having esotropia intermittently. So it's important to keep following up the child, because intermittent esotropias have a chance of becoming a true full-time esotropia and may require surgical intervention. So pseudo-esotropias, do follow up the child for a period of time. Ask parents to take photographs of the child, particularly when they think the child is esotropic. Often they will say that the child, when he looks on the side, because part of the cornea gets covered, they feel there is esotropia. So based on those photographs, you can actually see the photographs with flash on. That will be the most important thing. The most common type of esotropias that you see are the essential infantile esotropias. They are constant squints, onset between birth to 6 months of age, and that's why now it's called infantile and no more as congenital esotropias. And neurologically, the child is normal. It's the most common kind of strabismus, and although the exact cause is not clear, it is possibly because of an inborn and irreversible defect in the motor fusion mechanism. So there are a lot of esotropogenic factors like tonic convergence, high AC biratio, uncorrected hyperopia. Genetically, the child may be predisposed. Overlaying an immature visual system, unstable alignment during the first 4 months that we know exists in a normal child. Over time, as the normal motor fusion develops, the child becomes aligned and there is no strabismus. However, if there is a delay in the fusion mechanism to develop, the child can become esotropic with or without the presence of nystagmus. The characteristics are that they are constant squints essentially, they are large angle, they present even after 6 months of age, there is no apparent CNS involvement, and there is an asymmetric optokinetic nystagmus, essentially meaning that if the OKN drum is moved, temporal to nasal, there is smooth following and rapid refixation. So the kind of normal OKN you see. However, from nasal to temporal, there are jerky movements which are halting, and they are not so fast refixation. Other variable findings include refractive errors, amblyopia, apparent defective abduction. Often they are thought to be, because the child may be cross-fixator, he looks in the opposite field with one eye and the other with the opposite eye. They are thought to be, they are often confused as bilateral 6 nerves. You just patch one of the eyes and you'll see the movement complete. There is frequently presence of A and V patterns, DVDs, latent nystagmus, and anomalous head postures. There are syndromes associated with infantile syndromes like Ciancia syndrome, which has a latent nystagmus along with it, and the head turns towards the adducting eye. So he prefers to keep the fixing eye in adduction. The moment you switch the eye fixation, the head turns to the opposite side. Also Lang syndrome, which have esotropia, DVD, and X-cycloduction of the non-fixing eye. The differentials include a lot other causes, and of course acquired, which would be refractive, accommodative, nystagmus blockade, and sensory. So it's important to identify the differentials like accommodative esotropias, to look for pseudo-esotropias, Duans, where you are seeing a narrowing. You can see that there is a little narrowing here and abduction deficit in this side. So it's important for you to identify the differentials, not treat it like an esotropia. The treatment is hyperopic correction, manage amblyopia if it exists. Once it's freely alternating, go for surgery. Treat amblyopia before surgery, because the results of surgery are better. You can monitor amblyopia by the alternate squint and identify when the endpoint of equal vision is achieved. And of course, once you operate, the parents tend to neglect and may not follow up for amblyopia. The timing of surgery has been controversial. Early surgery is better chance of functional improvement, and this is how we would say that definitely by 6 to 12 months of age is the ideal time when we want to operate and align these. So it's not surgery, but alignment. Sometimes they require more than one surgeries, so it's important to get alignment by 1 year of age to get good binocularity. Accommodative esotropia is usually onset after 6 months and can actually present by 2-3 years of age when the hyperopia continues to increase. They are often detected, like I said, between 2 to 3 years. They can be associated or get precipitated by systemic factors. So the child falls ill and presents to you because the fusional vergence has broken, and and the accommodative esotropia has manifested. So it is not necessary that it is a sixth nerve palsy that has presented with the esotropia. They can be because of fusional breakage, and that can present with squint. The AC by A ratio is the accommodative convergence to accommodation relationship, which is an important factor on the type of and the management of accommodative esotropias. So you have a retinal image blur. The child makes no effort to accommodate. He's a relaxed type B personality. He remains orthotropic, but he may develop ametropic amblyopia. If there is again uncorrected hyperopia, the child is type A, he accommodates, he wants to see absolutely clearly. There is an accommodative convergence along with the accommodation. If there is sufficient fusional divergence, there is esophoria and the child remains aligned. He may break, like I said, in times of stress, and it can be insufficient fusional divergence. He'll present with refractive accommodative esotropia. It can be refractive accommodative, non-refractive accommodative, partially accommodative or hypoaccommodative. Refractive accommodative just requires a pair of glasses to correct them for both distance and near. The treatment is prescribing full cycloplegic correction. If the child initially does not accept it, keep him on cycloplegics for a moment. And it's important, the moment you refract, you give them the glasses immediately. Do not call the child for PMT. You need the cycloplegic effect so that the child accepts glasses. No role for surgery in these. In non-refractive accommodative, have a high AC by A ratio, so they may be aligned for distance or may have a small angle ESO for distance, but it increases markedly for near. It's because of an abnormally high AC by A ratio, and you require bifocals. As we showed in the first presentation, the bifocals should bisect the pupil so that the moment the child, the eyes go below primary position, it is assumed he's looking for a near target, and the accommodation should be prevented so that he does not develop an esotropia. Hypoaccommodative type have a near point of accommodation that is recessed. There may not be any deviation for distance, but a large esotropia for near, again require bifocals. For partially accommodative, there may be a correction even after the glasses, so you operate for the non-accommodative component only, and the patient is advised to continue wear glasses in the post-op period. There can be commitant esotropias that can manifest at much later ages, but they present have all the features like an infantile esotropia but are late onset. Cyclical esotropias may have a rhythm where the esotropia comes and remains aligned for a period of time. Over time, we know that they become fixed esotropes and would require surgical intervention. Acute comitant esotropia is one of the most important esotropias to be aware of, and if a younger child or an older child or an adult presents with acute onset esotropia, it may be associated with space occupying lesions, and it's important to image these patients. So just esotropias, do a cycloplegic refraction, no change, infantile esotropias, deviation fully corrected, prescribed glasses follow-up, they are refractive accommodative, deviation corrected for distance only, non-refractive accommodated would require bifocals, partly corrected, partially accommodative, surgery for the non-accommodated part. Thank you very much.
Thank you, Dr. Rohit. Now I would invite Dr. Pradeep Sharma. Sir himself is an authority and a master par excellence. He'll be talking on management of intermittent divergent squint.
Thank you, Ankur, and I thank Rohit for giving me this opportunity to be in this session of managing, and I would be talking about intermittent exotropia management, or maybe exotropias as such, which are much more commoner in our part of country than the esotropias. The exotropias may present, but the important thing that we have to remember is whenever you have an exotropia in infancy, you should always exclude a neurological problem. Exotropias may present in the form of infantile exotropia as intermittent exotropia, which is by far the most common presentation in exotropias. Then there can be sensory exotropias because of poor vision in one of the eyes. There can be consecutive exotropias after the surgery for esotropia earlier. Exotropia with neurological deficit, as I said earlier. Then there can be concomitant varieties of exotropias in the form of exo-DRS, in third nerve palsies, congenital fibrosis of extraocular muscles, and synergistic divergence. The infantile exotropia, which is constant, just like the infantile esotropia, remember it's an alternating type usually. It has a moderate to large angle, and there is usually no binocular potential. and these will have to be managed in infancy itself, just like the infantile esotropia. They are not the intermittent variety, so they have to be managed early. The intermittent exotropias mostly can be presenting in different forms. That means for distance and near fixation, if you measure, they will have a difference. And the earlier Burian's classification, which classified as divergence excess, simultaneous simulated divergence excess, or simulated divergence excess, which is seen by the +3, a basic type which is the same measurement for both distance and near fixation, or a convergence insufficiency type. And there is a modification by Kushner where he has subdivided and given some, in a way, the reason for having this difference, like the proximal convergence causing a true divergence excess, and a tenacious proximal fusional convergence, or what he now tries to call is the Scobie's phenomenon, which is by far the commoner variety of 40% of these cases. We also, if we see these cases in succession, we'll see initially they present as exophoria, being for distance, and orthophoria at near. They are mostly asymptomatic in this phase. They may proceed in the form of intermittent exotropia for distance and orthophoria or exophoria for near. Here they become symptomatic for distance. Then the third phase comes, that is exotropia for distance, exophoria or intermittent exotropia for near. Here the binocular vision for near is there, suppression scotoma is developing for distance. So this is a stage when we need to intervene. Exotropia at distance as well as both for near, this is a late stage where we may not regain full stereopsis. So they may have the presentation as we see. The near distance deviation difference is there. There is a larger exo for distance fixation compared for the near, and this is not intermittence alone. As you see, Spielman occluder, in spite of the near fixation, is having a lesser exotropia than what you have for distance. So whenever we do a patch test for divergence excess exo, and we should always do a 1-hour patch, and then if we find that the basic type is there, that means the deviation has become the same both for distance and near after the patch, means that the near initially was less but it becomes the same, then it would mean it's a simulated divergence excess of the first variety, which is because of a proximal fusional convergence or Scobie's phenomenon. If suppose we still have a difference for near and distance, we should give a +3 diopter, and if we have the higher AC by A ratio, then again you will find the basic type of exotropia is now getting manifested. Some cases may present as convergence insufficiency. That means for near, the deviation is much larger than what you have for distance. Again, they may vary in up and down gazes. They may have associated V patterns. That means in up gaze, the exo is more compared to the down gaze, and associated with inferior oblique overactions. Sometimes the inferior oblique overactions may not be there, and still there is a V. Or they may present as an A pattern. So they may have presenting in different forms, and I think we should be detecting it. There can be combinations of this. There can be divergence excess with a V pattern, and you need to check that because your management would depend on that. So what is the preferred practice pattern for a workup of an intermittent divergent squint? Measure prism bar cover test. Never use Hirschberg's alone. Near distance and even far distance of 20 meters should be taken into account. If there is a near distance discrepancy, do a prolonged patch of at least 1 hour and a +3 diopter if you still have a near distance discrepancy. Look for true pseudo V or A pattern. Look for the fusional divergences which are there. Look for the lateral incommittances. Some of the exotropias may have less exo in the side gazes. So there is a lateral incomitance, which would mean that you will have to reduce the amount of LR recession that you do. Look for associated, dissociated horizontal deviation. Reverse fixation test will help you in this. Look for the Newcastle score to monitor the control that they are having, or objectively you can do by measuring the stereopsis. So the non-surgical management of IDS would include, first of all, glasses. I think Dr. Rohit has covered this part. Orthoptic exercises are an important thing if we are dealing with an exophoria or intermittent exotropia in which there are having poor fusional convergences, and you can improve them by giving proper exercises. And mind you, they are very effective provided we explain to them the physiological diplopia. Many a times the way is prescribed is they are doing only pencil push-ups, they are only helping their biceps. So I think we have to be careful what we are advising. Overminus lenses is another approach as a non-surgical approach, in which usually we do it for those cases which have a high AC by ratio in children. Occlusion amblyopia therapy has also been described as one of the modalities, but I think it is not a very useful one, and I think Dr. Saurabh Jain is there. There was a study done in Britain recently also, and they have shown that it's not much effective. So Overminus lenses. Timing for surgery is important in intermittent exotropia. And we usually say that if it is manifesting more than 50% of the time, we need to intervene. If we have the Newcastle score possible, that means we are dealing with little older children, we can see the Newcastle score of there. And if we can do the stereopsis, still better. The Newcastle score, most of you must be aware, is this way we can grade the amount of control that they have. The near stereopsis by the TNO test here or the Randot test can help us in actually seeing how much of damage the exotropia has done. Similarly for distance, because as you know, exotropia manifests first for distance and more often for distance, a distance stereoacuity will tell us earlier what is happening to their control. And this you can do with the distance Randot, which is not a very good test, but the better test is the Frisbee-Davis distance, an FD2 test, which is an objective way of seeing how much stereoacuity is there for distance. And we have done a study which we published in BJO some time back, in which we had shown that the distance stereoacuity gets affected in intermittent exotropia, but can be reversed and improved if we operate in time. So timing is critical. Timing is taming. That's important. The decision tree that you need to remember is here. This is like Schindler's List. The book of Kushner's recently, which has come, is given very nicely. Some of these things, you can see the Kushner's list. The choice of surgical procedure, just simplified, is this. In basic exotropias, we prefer to do R&R in adults. In children, we may still do a bilateral LR recessions. In true divergence excess, we prefer to do a bilateral LR recession, and sometimes we may have to do optical corrections for near in addition, because they may have a high AC by ratio. Simulated divergence excess occlusion can be given, and we can confirm if it is true or the simulated type, and then bilateral LR recessions can be done. +3 diopter, if we are detecting, then we need to add bifocals in this. Convergence insufficiency type, which is truly there, then we have to do a bimedial resections or prisms, and these are the variety which are a little more difficult to treat. A tight LR may cause an X pattern, and concomitant vertical deviations may be there. Remember, overcorrection in older children or adults is required because there is a post-op exo drift. But in children less than 6 years, we always try to do a undercorrection, if at all, so that we do not have an esotropia and the problems of amblyopia. The risk factors of under and overcorrection should be kept in mind. If you have more than 15 prism diopters, then you will have to intervene after 3 months. And you can manage the overcorrections in children by seeing that they do not have a problem because of amblyopia. But again, I would like to say that it's not just surgery to improve fusional convergence. We will have to add on, and we can improve the convergence in these children and restore binocularity in its fullest measure. Thank you all. Our goal is not just correcting strabismus, but to restore the stereopsis that God gave us. Thank you all.
Thank you very much, sir. That was wonderfully discussed about the management of intermittent divergent squint. I will now invite Dr. Ankur Sinha, who would be telling us about decision making in squint surgery. So what are the steps and what are the important things we need to know when we are deciding for squint?
Thank you, Dr. Rohit. Thank you, AIOS, for giving me the opportunity. I'll be talking about decision making in squint surgery. So we have already discussed the requisites before surgical planning is refraction, proper glasses, assessment of BCVA, amblyopia therapy if needed, assessment of strabismus constituting history, sensory status, and the motor status. So the basic principle of surgery are two: weakening and strengthening of muscles, and both of them are misnomers, because there is no true weakening or no true strengthening of the muscles. There is no limited rotation of globe, or there is no true increase in the muscle power. What we are doing is just altering the length tension curve of the muscle. So here are the various procedures, weakening procedures for recti, the common being recession and the Farden, and the various strengthening procedures of the recti, the common being the resection. At times people can do tuck and cinching also. This table shows you the maximum and minimum of each muscle. So for the medial rectus, it varies from 2.5 millimeters to around 6 millimeters. For lateral rectus, it is 4 to 9 millimeters. For superior rectus and inferior rectus, it is 2.5 to 5 millimeters of recessions for a comitant strabismus. Now a few points. Bilateral recessions, they are preferred under GA because if at all there are any globe position changes, they are equal or none. They are reversible as there is no loss of tissue. Recession resection, they give you more effect per millimeter of surgery, but it has to be understood that we are not dealing with 2 recti at one sitting or 3 recti in one lifetime of the patient. Widening and narrowing of palpebral fissure can occur with horizontal muscle surgery. Large recessions can give you widening and large resections can give you narrowing. Ptosis and lid retraction can be seen with vertical recti muscle surgeries. It has been reported to as high as more than 90% in both IR and SR surgeries. Lateral rectus surgery, we have to be very careful not to include inferior oblique, because inferior oblique inclusion has been reported in up to 1/3 of cases. For medial rectus surgery, we have to be very, very careful. At times, you have a tight medial rectus and long-standing esotropias, and they are very prone to pitting and being lost. For inferior rectus surgery, there is a direct proportional effect. The maximum limit is 5 millimeters. You have to be careful for the capsulopalpable fascia and the attachment with the lower lid retractors in the lower part of the inferior rectus. Similarly, you have to take care of the anatomy of the LPS and the SR, superior rectus associated with the superior rectus surgery and superior oblique. And large recessions or 10 millimeters or more can produce some kind of lid changes in these patients. Now we talk about surgical dosage. Recession is a stronger surgery than resection. Medial recti tend to respond more as compared to lateral recti. Larger deviations tend to have a better or more response as compared to smaller deviations. Younger patients do tend to have more response, and there are certain patient factors and surgeon factors which one has to tame and understand. So now this is a patient who is having a partially accommodative esotropia, and what we want to plan for her is to correct only the deviation with the glasses on. So we have to be very, very careful in such cases. And we do the panning up and down gaze, lateral gazes, and the tertiary gazes. There is no oblique overaction, no concomitants in any of the gazes. So we plan for a single muscle surgery, a recession of medial rectus by 5 millimeters, which is giving you approximately 3 millimeters, 3 prism diopters per millimeter of surgery. Now, this is another case of divergent squint showing you 45 prism diopters of exotropia. Again, no concomitants, and the patient is being planned for surgery. We are planning lateral rectus 8 millimeters and medial rectus 6 millimeters. How do we come to this? Is we multiply LR by 2 and multiply the millimeters of MR by 3. So we get 17 for the lateral rectus and 18 for the medial rectus. So when we add them together, we get 35, and we do RNR together, we get 25% more effect, which is around 8.75. So we're planning to correct around 44 prism diopters in this case of 45 prism diopters. There are certain variations in your own calculations depending upon the surgeon's factor, and of course the patient's factor can give you some amount of surprises. So this is a post-op photograph of the same patient. Now, at times you have unacceptable consecutive deviations, like this is a consecutive esotropia with diplopia of 30 prism diopters. So old records mentioned it's a basic IDS having 30 prism diopters base in prisms of deviation. TNO was a little poor, and the planning was bilateral LR recessions by 7 millimeters. So since we have the old records, we know the 7 millimeters into 2 should give you 14 millimeters. 14 millimeters of the LR has been done. So 14 millimeters should give you 28 prism diopters of correction, but it has given around 60 prism diopters of correction in this patient. So what we do normally for a 30 prism diopter esotropia is do 4.5 to 5 millimeters of MR recessions of both eyes. So in this case, the response is double than what we will anticipate. So we go ahead and do the surgery. After waiting for 6 weeks, we just do one eye by 5 millimeters, and this corrects around 30 prism diopters of esotropia in this patient. So sometimes patient factors do have bearing on the effect of the muscles, effect of the results. Now, certain considerations like distance near variations, sir has already talked about it, pattern deviations, oblique overactions, DVDs, head postures, and limitations of movement which could be paretic or restrictive. So if there is a distance near variation, MR resection will be preferred in case of IDS, and if it's an esotropia which is having a distance near variation, we have to recheck the glasses, give them bifocals, and may need to add Fardin to the recession surgery which we are going to perform in this patient. Pattern deviation is measured in 25 degrees up gaze and 35 degrees down gaze. Difference of 15 prism diopters for V and 10 prism diopters for A is considered as significant. So this is how, we identify the A or V pattern in different gazes in distance and near. And when we plan for surgery, if it's an oblique overaction, we have to plan oblique surgery, and oblique response to weakening surgery is better as compared to strengthening surgeries. And we can also plan vertical shifting of the horizontal recti if there is no oblique overaction. So we have to always remember that the medial rectus has to be shifted towards the apex of A or V. So likewise, lateral rectus has to be shifted toward the base of the A or V, as we are doing in these patients. And very important, do not ever miss obliques, because if you look in the primary gaze, the patient looks like to have exotropia, but you look into the tertiary gaze, she continues to have elevation in adduction, giving you the indication that there's inferior oblique overaction in both eyes of this patient. Similarly, this is a patient of A pattern esotropia, where both the eyes are showing superior oblique overactions here. So we can grade the inferior oblique overactions from 1 to 4 depending upon the elevation we achieve in the adduction. And there are the various types of grade 1, 2, 3, 4 inferior oblique overactions in all different patients. Depending upon the oblique overaction, you can plan 8 millimeter recession in up to 1. 10 millimeter recession with the Parks or Shee's method, we can do it that way. For significant overactions, press 3, we can do Elite and Nankin's procedure, but there can be a depressor action if you are doing Elite and Nankin. With modified Elite and Nankin, this depressive action of inferior oblique is gone. And for 4+, we can do anterior and nasal transposition of the inferior oblique muscle. Now, this is another patient which is showing you increase in the exodeviation in up and the down gaze. But here, the cause is not the inferior oblique overactions, but it is a DVD. There is slight R oval L, and this is because of the disruption of the fusion by the nasal bridge. That is why she's having this inferior oblique overaction-like picture. So she has a 14 prism diopters of exo with DVD left eye more than the right eye. For a 14 prism diopter, ideally we should do a 7 millimeter lateral rectus recession. But we plan for 5 because the patient has DVD. So this is the DVD which is being shown to you. And under the Spielman, we can see that the eye goes up and out. And similarly, when we shift Spielman from this eye to this eye goes up and out. So it's a case of bilateral DVD where the left eye is having more DVD as compared to the right eye. So what we plan is superior rectus of the right eye 7 millimeters, lateral rectus by 10 millimeters, and LR recession by 5 millimeters. So we have to underdo the calculation for exo and overdo for ESO if there is a DVD associated. Now this is the video which is post-surgery. We can see now the eye doesn't go up and out with the Spielman's occluder. Or if at all, there is a very small amount of movement. So we have to look for the head postures also. Head postures could be a tilt, turn, or chin up or down. And there can be various reasons for it. The commonest reason being, if it is significant as head posture, we have to look back at the photographs, child's photographs, and it is because of the nystagmus. And it's the same patient where the null shifting surgery has been done. FDT will help us know whether the limitation is due to underaction or restriction, because that will help us in finding out the cause and choosing the muscle surgery, what you want to do. You have to gently lift the muscle and move in the direction of action so that we can find out whether it is tight, the opposite muscle is tight or loose. This is the case of bilateral slipped muscle. We can clearly see the eye is not adducting at all. Not the right eye and the left eye, both are not adducting at all. Even in the ductions, they are not moving inside. So here we'll have to plan for advancement of the muscles. So this is the right eye where the muscle has been advanced. We can see now the excursion is better, but in the left eye, the advancement has not been done as of now, so it is not inducting too much. So for paralytic and restricted strabismus, we will have Dr. Saurabh Jain will be talking about these. So accurate measurement of deviation, sensory test status, good assessment of eye movements, specific tests if needed, and choice of correct procedure, they are must to achieve good results in strabismus. Thank you.
Thank you, Dr. Ankur. We'll now move on to Professor Rohit Saxena. Sir will be now talking about the steps in squint surgery in a video-assisted approach, and we'll then see the actual procedure of the squint surgery now.
Thank you. So I'll just go straight to the videos. There's not, it's not moving. Yeah. So just a comparison, just one important thing, there is earlier we used to use the limbal incision. Now I'll be showing you actually the fornix incision. There's not much difference. The important thing is that the limbal incision is obviously at the limbus. The fornix is 8 millimeters in the fornix. The advantage is that there is minimal bleed if you are in the correct plane, because the limbal vasculature is not affected and you're not opening that up. So there is minimal bleed. Initially there will be a little ooze if you open it at the limbal area. The limbal incision is technically easy. It is good for beginners because you can understand the anatomy, you have good exposure, so the risks of operating the wrong muscle is not there. But for fornix, it's a little technically difficult. You need a good assistant who uses nimble fingers rather than the biceps to open the conjunctiva, and it can be a little difficult for beginners because the exposure is not so great. So I'll just show you a recession. So this is a fornix incision. The tenons has been exposed. We are on the sclera. You can see the sclera. We've opened that up, widened it. We are hooking the muscle with the Jemisin's hook so that we are in the right plane. We go a little inverted. The face is little opposite when we go in. The Green's hook with the notch, which prevents the slippage of the muscle when we are pulling it out of the opening we have made. Then we make an opening in the superior intermuscular septum, and we need to be able to see the sclera here before we actually pass the lens hook. But again, you must confirm that you have the upper end of the muscle. Sometimes if you don't, you will split the muscle, and that will cause a severe amount of bleeding besides damage to the muscle which you are trying to recess. Then you cut the check ligaments. It's important to, particularly lateral rectus, you have the inferior oblique lying there, so it's very important to be careful you do not damage the inferior oblique. If you use a single suture, you can tie a central knot, and then on the sides you can pass partial thickness and then full thickness sutures, so that you can take all levels of the muscle. So you have the anterior fibers as well as the posterior fibers, and right to the edge, so that the entire muscle is included. You leave a very small stump. Again, it's very important to be consistent in what you do. Again, your measurements, you're holding it from the middle, and at the edge where the muscle is, the original insertion was, you measure from there, so that you get the correct recession that you are planning for. Because when you hold it from the middle, you'll be distorting the insertion a little. Partial thickness sutures, where you have made the mark, again you have to pass it directly where you've placed the mark. Otherwise, again, even 1 or 2 millimeter displacement up or down or to the side can change the amount of the kind of results that you're getting. You need to make sure that after you have tied, there is no other tissue attached to the insertion, which can make changes because the fibrosis can happen. You can cauterize the stump slightly so that it does not bleed, and then the fornix incision can be nicely closed with 1 or 2 sutures. It's important that you close it on the temporal side, because when the eye adducts, the lateral opening can actually open up, but on the medial side, usually it does not create that many problems, and it gets hidden in below the caruncle. So this is again a fornix incision for a resection surgery. Again, you have opened the conjunctiva, we have opened the tenons just above the sclera. The hook is passed initially opposite end and rolled over the sclera, so that no tissue is grasped. You are on the sclera. Again, you prolapse out the muscle out of the opening that you have created. You make sure that your tip is visible, and then you make an opening in the superior intermuscular septum. You bring out the hook, and then you need to confirm that you have the entire muscle. Again, you cut the check ligaments. It's for recession, it's extremely important that you clear the check ligaments properly for resection, because it is not sometimes absolutely essential, but you need to do it till the place where you are going to pass the sutures. So for resection, we prefer to use double-armed sutures. You pass one on the opposite side, and then the original needle onto the inner side, so that you have 2 arms of the suture superiorly, and similarly you will have a double-armed suture for the inferior part of the muscle. So essentially there are 4 needles that you're looking at. You can cauterize the muscle anterior to the part which you're going to resect, cut it, and then you remove the stump. Again, you leave a small millimeter of the stump so that you can pass the sutures, but the sutures are not to be passed through the stump. They have to be passed through the sclera under the stump, so that it does not, there's no cheese wiring, and the effect of your resection is not lost. So you nicely spread out along the insertion, so that your final insertion is nicely spread and it does not clump in the middle, although some amount of clumping is expected because the sutures clump the muscle. So double armed, so that there is no risk of the muscle getting lost, or even if one suture gets broken, it still remains there. And again, the conjunctiva is closed over it. I'll just escape this and do a plication, just show you plication, because time is a little less, so I'll speed it up quickly. So I'll essentially show you the steps of plication. The process is the same. The entry of approach to the muscle and hooking the muscle, all the steps are the same. the important thing is the way we pass sutures. We can use again 2 double arm sutures. In this I'm just showing you, I used a single arm suture for the superior and the inferior, just modified the way we pass the sutures, but you can do it just the way it is done for a resection. Just that you do not cut the part anteriorly, but the knuckle of the extra tendon that is there, it is preferable that you put it on the inside so that it does not come up and show up in the post-op period. So you nicely pass the sutures at the place from where you want to do the plication, the amount of plication that you want to do. The passage of the sutures is almost the same. The same needle, I pass it reverse so that the needle is coming out from the middle. You have the lateral sutures as well as the middle suture. Similarly, the same is done for the inferior part of the plication. A single suture is being passed on both sides inferiorly, and then I'll pass it back into the center. So this is how we are going to have 2 sutures here. We have 2 sutures with a long arm on both sides. This is the reverse that I'm passing it so that it comes out through the middle. Just a little, like I said, a change that I do when now we are going to pass the suture at the insertion. It's important to know where we are passing. So I've brought it out from underneath the muscle here at the insertion, and similarly past the suture. Here you can see the suture is being passed at the stump and not through the muscle. This is the change that we do. We do not pass it at the muscle, we pass it through the sclera underneath the stump, and the suture is now brought out over the muscle there. Again, the upper end is brought through the muscle here. The suture is passed at the sclera. You can see the sclera is being visualized clearly, and we are passing it at the sclera at the original insertion. And then the reverse is passed. Like I said, you can use 2 needles for this. It's a little more cumbersome, definitely more safe, but just for the sake of speed, I generally use this as a single suture. And then you pass it at the edge, and now you have both the arms coming up. Now you pull them together, and the extra knuckle, you push it underneath so that the suture is being tied over the tendon, and the 2 ends come together. So that's, we'll just pull it. So I'm pulling the 2 sutures so that they are coming closer together, and the extra knuckle is pushed underneath so that now the plicated part is now come to the original insertion. And you tie it, and you make sure that that there is no gap or there is no gaping at any point. You can take an extra suture at the sclera so that you tie the whole thing together. So this is, sometimes I take an extra suture through the sclera so that I make sure that the plication is complete. The knuckle is underneath the plicated muscle and therefore does not come in the way of the eye movements and does not show so much in the post-op period, which is one of the problems associated with plication. And the closure is just the way as we normally do. So this is plication, and so these are the steps of squint surgery. We can take 1 or 2 questions before we go on to the keynote address, if there are any.
Yeah. We have a question here.
So I'd like to ask you whether you do reoperations on patients who develop consecutive deviations.
Reoperations
Yeah,
on
in the sense
consecutive.
Yeah.
So do you mean whether I tackle the same muscle or we tackle a fresh muscle?
Same muscle, because the fresh muscle
Yes.
is always available. Whereas
Yes.
if you have a operated muscle, you've already reset it by so much.
Definitive indications of operating the same muscle would be if I fear that there is a slippage of one of the muscles, like it was shown for advancement. That is a definitive indication of looking at, or there is any limitation of movement, there are restrictions which I need to clear. If there is a limitation of movement, I need to go in and re-explore that muscle and identify.
No, with the aging of the child, supposing the patient has got an ESO and he's going to become an
Okay, so
exo.
over time he's become a consecutive
Yes,
exo.
yes.
So you have an option. If you know the exact surgery that was done, maybe you can go and do an advancement if it was, say, a medial rectus recession and it's a consecutive exo. But you can just do de novo fresh lateral recti and correct it. More often I prefer that because that is more predictable in my hands, especially, like I said, if I do not know what the previous surgery was.
Thank you.
We'll have one more question there, and then we'll have the keynote address.
For part-time occlusion, which half of the day you prefer?
Of course, there will be different opinions. It's not essential that there is any fix, but I generally prefer the part-time occlusion to be at home under supervision. And at that time, the child can be encouraged to play games, video games and all. In school, children are very bright. They're brighter than us. They open a small chink and use their better eye. And of course, it's more traumatic socially for a child to be ridiculed in school for the patch. So I would always say at home, 6 waking hours at home with active vision therapy. Thank you. Now it's my pleasure to invite Dr. Saurabh Jain, who is a consultant ophthalmologist and training program director for ophthalmology residency in London. He has a special interest in pediatric ophthalmology and adult strabismus. And although his mannerisms and his speech is all Englishman-like, he's actually our own very Indian. He did his undergraduation and post-graduation from MAMC. And so it's my pleasure to invite Dr. Saurabh Jain, who will be talking on challenges in the management of concomitant strabismus.
Thank you very much, Professor Rohit, and to the program committee for this honor. As you quite rightly say, my journey in ophthalmology started in India, and it's a real honor to be back. I'd also like to thank the speakers who've come before me. We've had some excellent talks today and some fantastic videos, and a lot of what I say will build on what's already been talked about today. I'm told that I'm sandwiching a session between basic and more complex strabismus, and I cannot think of any topic better to do this than concomitant strabismus. So can you just see if this doesn't seem to be moving? So concomitant strabismus, very simply, is a strabismus that's different in different directions of gaze. You can see here a patient who has a bit of an exotropia in straight gaze, which is more in right than in left gaze. So the definition might be simple, but managing these patients is very challenging. Why? Because the deviation is different in different directions of gaze. So even before you start doing anything, you have to adjust the expectations very, very carefully. And the second reason why these patients are challenging is doesn't seem to be moving. Can you see? My talk doesn't seem to be moving. Okay. Oh, you can move it for me. Great. So, and the other thing is the causes of concomitant squint always raise a red flag. So an acquired concomitant squint needs to be investigated. Is it a neurological problem, or is it a mechanical limitation because of thyroid problem or myasthenia? You have a few congenital forms of concomitant squint, but a lot of these squints are acquired and need to be investigated quite carefully. So I have a strabismus theatre every Monday morning, and before this, me and my fellow registrar have a little talk about what we're going to do. And the most amount of questions are about concomitant strabismus, which muscle, which eye, how much. And over time, I developed a few rules which I think help me. Now, like all good rules, they're meant to be broken, and I break them on a daily basis, but I think they will serve as a basis for discussion. So can you have the next slide, please? So just a little bit of revision for the more junior members. These are the muscles that move our eyes around, and every time you make a movement of both eyes, a yoke muscle pair comes into view. So if we can we have the, so when you look to the right is the right lateral rectus and the left medial rectus. That can we just have the no, that's fine. I've got the pointer. So when you look to the right is the right lateral rectus and the left middle rectus at work. So that's dextroversion. Do you mind just going next? Yeah, next. And when you look up and to the right is the right superior rectus and the left inferior oblique. Now we'll come back to the diagram again during the course of this talk. Next slide, please. So I insist on 9-gaze measurements for a lot of my patients, much to the dismay of my orthoptist. So here's a 9-gaze measurement, which basically shows the concomitant squint. The deviation is almost the same in all directions of gaze. Next, please. But here you see the situation is a little bit different. This is a patient that also has an esotropia, but it is much more on the right side. And next, please. So next, so going back to our diagram, so which are the two muscles that work on the right side? Well, the right lateral rectus and the left medial rectus. So therefore, there must be a problem either with an underaction of the right lateral rectus or an overaction of the left medial rectus, or both. So, next, please. Next. Next. So by using this, all of this information we have, we conclude this is a right lateral rectus underaction or a right sixth nerve palsy. So you can use the 9-gaze and knowledge of anatomy not only for the diagnosis but also for the management. Next, please. So here's the patient. Can you click on it, please? So here's the patient we were talking about. You just click on the video, it should start playing. No, just go back, click on the video. And just go back and you can click on the, do you want me to do it? Yeah, there we go. Just click on the video. This is the patient we're talking about. So you can see he has a right esotropia. I'm going to ask him to look to the right. Very little lateral rectus function. So this is the patient we're talking about, a patient with the right sixth nerve palsy. Now, what can we do for him? Well, the first thing is, this is an incomitant squint. His deviation is much more in the right gaze. Second thing, we know he has a head turn to the right. Next, please. So here's my first rule. If you're going to do anything for these patients, target your direction of gaze where the deviation is the most. And why do you want to do this? Well, this is a binocular field of single vision, which I find very, very useful. You can do this on any octopus perimeter. And you can see the whole right side of the field is diplopic, including the fixation point. So this crescent here is the only place where you see single thing on the left. So what you want to do, you want to move this to the center to eliminate his head turn. How can you do that? Well, if you have some lateral rectus function, you can do a recession of the MR. But if you have no function at all, if there's a dead muscle, you have to use a neighbor. Next, please. And this is what, so you can do a transposition, you can do a full tendon or a split tendon or the Nishida procedure. All of them have their own proponents. For this patient, next, please. I used a crouch procedure. I like this very much because, as one of our speakers said, you really don't want to do more than 2 recti at one time. Using this procedure, you just move the superior rectus to the lateral rectus, put in a posterior fixation suture, and you recess the medial rectus on an adjustable. So you're just using 2 muscles, but you have a safety net of a recession, and you have a very, very powerful abducting force. Next, please. Can you just click on the video? And this is the same patient I showed you at week 4. And you can see now, the eye has settled, and you can see he's actually a little bit exophoric. I'll just show you the ocular motility in a minute. You'll see just by using 2 muscles, you've given him quite good ocular motility. Now, note he still doesn't have full abduction, and you have to warn these patients in incompetent strabismus. You are not, you're not chasing perfection here. Next, please. Also be very aware of the secondary effects of your surgery. So every time you recess a muscle, you get an effect in primary position. But when that muscle works, you get an augmented effect when in the direction of action of that muscle. And these effects can augment or detract from your intended aim of surgery. And it's best to be aware of them so you can actually use them to your advantage. Next, please. To give you an example, in this case, we did a right, we improved the right abduction. Okay? But what you could have done, you could have weakened the left medial rectus. Now they would have given you an improvement in primary gaze, but when this patient looks to the right, you get a secondary limitation of or weakening of this muscle, causing a further collapse in this angle here. So that would have been something else you could have considered. Next, please. My recessions on the whole are hangback because I do a lot of teaching and training, and I find it's very easy to train residents on these because you're doing all your suturing here, where you have better where you have better exposure, and also then you can use this with an adjustable suture. Next, please. So here's my second rule. You try and target the muscle that move the eye in the direction of maximum deviation, if at all possible. Next, please. So I'm going to show you this video. You can go to the next. So this is a 30-year-old. Can you click on it, please? A 30-year-old who came to us because he had vertical diplopia for as long as he could remember, and he was now finding it difficult to read. So you can see this is primary gaze, looks to the right, and you can see quite marked left over right. Okay? So this very clearly is a left fourth nerve palsy. It appears to be congenital because it's quite a large deviation. When it looks to the other side, there's hardly any deviation at all. Next, please. So this is now the 9 gaze. It's a little bit more complicated here. Why? Because there are 3 measurements. The top one is the horizontal, this is the vertical, this is the torsion. And you can see this patient has 3 kinds of strabismus. Okay? So how do you go about deciding what to do in this case? Next, please. The first thing is to see, well, where is the deviation the most? He's got a lot of excyclotorsion in down gaze, and he's complaining, next please, of difficulties in reading. Also, he has a left over right, much more in dextroversion as you would imagine, but also much more in down gaze. So based on this, next please, we started to do, okay, next. Next. So in dextrodepression, the two muscles that work are the right inferior and the left superior oblique. And based on the axial torsion and everything we talked about, we decided to do a superior oblique application procedure. Okay, next, please. Next. Just click on the video, please. So what you can do is before you start, you can do an FDT. So here I'm pushing the eye up and in, and you can see because of loose tendon, you can really push the eye in and get a very good idea of the laxity of the tendon. You do a superior oblique tuck, and you see post-tuck, you have induced a Brown syndrome, and this is what you're aiming for, really. Next, please. What you want next? So what you want to do is when you finished your tuck, is you need to be able to push the eye just above a line joining the medial and the lateral canthus, giving you an idea of the completeness of your procedure. Next, please. This is the next example. This gentleman came to us for a retinopexy in the left eye, and he had a local anesthetic injection for that. Next, please. And we found out after the injection, the left eye would not go up. Next, please. So this is the deviation. So he's got a right over left, more in up gaze here. So why did this happen? Well, we all know about the myotoxicity of local anesthetics. If you get an injection within a muscle, next please, the bupivacaine can cause selective destruction of the myofibrils. And once they're destroyed, they regenerate, and it leads to, you can see this pre and post, a big hypertrophied muscle, and this is now pulling the eye down. Next, please. So, and you can please click on the video. So, and you can see now on a force reduction test, this is me pulling the eye up, and this is me pushing the eye down. So you can see I can push the eye all the way down very easily, or you try and push the eye up, and you will feel the resistance. So an FDT is a really important test when it comes to managing these cases. Next, please. So once we knew there was a restriction, that's what we did. This is my third rule: is a restriction or mechanical limitation, introduce it if at all possible. Okay, just one more to go. This is the last case. This is a patient, quite complicated. He has thyroid eye disease, as is very evident. He's had bilateral decompressions and bilateral infected recessions. His problem is very simple. He sees double when he looks down. Next, please. And this is the problem. So he's got a right over left in down gaze. Now, okay, it would have been a very simple thing to do a recession of the left inferior rectus to match this limitation, but it's already been recessed. So what can you do? Next, please. You can do a retroequatorial myopexy or a Pardon's procedure. The advantage of this procedure is what you're doing is you're attacking the muscle to the globe behind the equator, reducing the movement arm. So there's no effect in primary gaze, but every time the patient uses this muscle, you'll get a selective weakening. Next, please. An alternative is you could do a Scott's procedure, which is a combined resection of the same muscle, so you get the exact same effect. Next, please. But it can be adjusted. You can do an adjustable. Next, please. And this is my last rule. Okay, if it's not possible to release a limitation or restriction, aim to match it in the contralateral eye if the patient will let you. Next, please. And this is the summary of everything I've talked about. Incompetent strabismus is a surgical challenge. You need to counsel these patients properly. Target the muscle to move the eyes in the direction where the deviation is the greatest to center the binocular field. If you feel there's a restriction, try to release it. If you cannot release it, try and match it. Next, please. Thank you very much for your attention.
Thank you very much, Dr. Saurabh Jain. If there are any questions, one or two we can take. Otherwise, we'll having a back-to-back squint session. Professor Pradeep Sharma's session on advanced strabismus is there. So I'll ask Professor Pradeep Sharma to now come to the dais and start his session.